Welcome to the Cherry Pal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, today we're going to be talking about comprehensive dementia care management. Does it work?
Does it work?
Does it work? Who are our guests with us today?
Our guests today, we're delighted to welcome back David Reuben, who's a geriatrician, professor of medicine, director of the Alzheimer's and Dementia Care Program, and director of the GUIDE program at UCLA. David, welcome back to the Cherry Pal podcast.
Glad to be here. Thank you.
Seems like a good guest for answering that question. We have another guest with us.
We also have Greg Sachs, who's a geriatrician and palliative care doc and chief of general internal medicine and geriatrics at Indiana University. Greg, welcome to the Cherry Pal podcast.
Thanks. It's a pleasure to be here.
So recently we just got 2 JAMA publications authored by our guests that we have links to a podcast around this question about dementia care management programs. But before we go into this topic, Greg, I think you have a song request for Alex.
Yes, John Lennon's Give Peace a Chance.
Why did you pick this song?
When my team and I were working on the pilot grant for this program, were enough of us of an age where the Beatles and John Lennon sort of resonate. So this is the mug my team got me.
What does your mug say for our people listening on audio?
Give In Peace a Chance. And the other side of the mug is not a picture of my face, but it's John Lennon.
So the trial was called In Peace. How long did it take you to come up with that acronym, In Peace?
Not long, because we had done a study previously at the University of Chicago called PEACE, Palliative Excellence in Alzheimer's Care Efforts. And when you move to Indiana, you can slap IN on the beginning of anything.
That's great. All right, here's a little bit. Everybody's talking about bagism, shagism, dragism, madism, ragism, tagism, thisism, thatism. Isn't it the most? All we are saying is give peace a chance. All we are saying is give peace a chance.
We will talk more whether or not we should give In Peace a chance, but I was wondering, maybe we could take a big step back. I'm going to start with you, Greg. How did you get interested in, it sounds like you've been interested in this a while, this idea of comprehensive dementia care management?
Well, you could go back to an editorial I had the fortune of writing in the New England Journal in 2009, where I go into it in more depth. But basically, I grew up watching my grandmother die from dementia, receiving very poor care, dying with no palliative care in place, and with lots of bad things happening to her, eventually in the nursing home. And so for essentially decades, the idea of trying to improve care for people with dementia and their families has been a real core of what I've been driven by.
And for our listeners who may have not read it, we will have a link to that New England Journal editorial. If you can describe, like, what were the biggest things that you were seeing that was wrong with the care that we were delivering?
Well, at that time, I think it was very frequent for people to end up in nursing facilities without any kind of supportive care. They were sedated or given psychotropic medications, and things were done to manage them at the convenience of the staff rather than trying to improve the quality of life of the residents and support their families. And there was literally nothing in the way of palliative care or hospice that was provided to patients with dementia at that time. And that's changed dramatically, and I think that's a good thing, but it still is a piece that needs to be integrated into dementia care management programs, the palliative care part.
Yeah, and we'll talk about your trial In Peace, about layering that palliative care into these comprehensive care management programs. Before we do, Dave, you've also been doing this for quite a long time. How did you get interested in creating these programs?
Well, I've been doing basically kind of practice redesign research for close to 30 years. And I got a little sidetracked. I was doing a lot of work for the ABIM, including chairing its board. And when I stepped down from that, when I rotated off, my emails dropped in half. And I said, geez, I have some time on my hands. Meanwhile, one of my partner's patients was a man whose wife had Alzheimer's. I covered for her when she was on the inpatient service, and he wanted to do something for Alzheimer's disease. And so I said, that's a very needy population. And as I learned more about it and looked at models, including the Indiana model, I realized just how much needs to be done and how terribly devastating this disease is. So I began to focus almost exclusively on dementia, a little bit on falls, but mostly on dementia. And it's been incredibly gratifying.
Mm-hmm. And both of you just published some really big studies that usually we wait a little while to dive into it. I think it's important because I think it's, as we think about kind of next steps moving forward, what we should learn from it. Maybe we can start off with your trial, David, thinking about what you're doing at UCLA with this comprehensive DCARE trial. Is that DCARE, right?
Yeah, DCARE is the name of the study.
What does DCARE stand for?
The Dementia Care Study. It's not an acronym.
Real briefly, what did you do in this study?
So it wasn't actually done at UCLA. None of the clinical trial sites, the 4 clinical trial sites, 2 were in Texas, 1 was in Pennsylvania, and 1 was in North Carolina. So we randomized dyads, basically persons living with dementia and their caregivers, to one of 3 arms. One arm is health system dementia care, which is based off of the UCLA Alzheimer's and Dementia Care Program. It involved co-management with a nurse practitioner or a physician's assistant who is based in the healthcare system. Second arm was community-based.
Before we go into that, for that arm, did they have specific training on how to care for dementia, or were they just nurse practitioners?
Yes. They got trained out the yin-yang. Yeah. So they got trained, monitored, fidelity, all sorts of fidelity things. The second arm was community-based dementia care. And that was dementia care that was delivered in community-based organizations. Could have been the Alzheimer's Association, and it could have been a senior center, but they had a dementia care special manager called a care consultant who was either a master's in social work or a bachelor's nurse. And all of that care was delivered telephonically. And then the third arm was usual care, and we threw in the 1-800 Alzheimer's Association helpline that people can call.
And the difference between the healthcare system-based and the community-based, was the content that they covered and they helped with similar?
The content was not different. It was who was providing it and how.
Mm-hmm. Okay.
In fact, we're looking right now, in the next 2 weeks we should finish up, we're looking at all the quality indicators and see whether they differed or not. But basically, the kind of care was very similar. It was who was doing it, how they were doing it.
Yeah. And I just want to also acknowledge that both of your studies took place during COVID. I'm guessing that influenced a little bit of how, because initially the healthcare system was supposed to be in person.
It was in person, yeah.
And did that shift with COVID?
Oh, yes. Yeah. 9 months into the study, March 16th, 2020, all clinical trial research stopped.
Yeah.
Mm-hmm. And across the country, not just in dementia care. But we got back into the field relatively soon, in May. But we had to switch, instead of in-person care by the dementia care specialist in the healthcare system arm, to telephone and virtual.
Mm-hmm. So does that mean that the 2 interventions started looking very similar?
They look more similar. It was different kinds of people delivering them and different access to the healthcare records and such like that and consultants, but they were not touching people.
Okay.
And just back to the dyads, the people with dementia, how would you characterize them in terms of dementia severity?
They were relatively severe. We did a version of MOCA that was administered over the telephone, and they would be considered at least moderate to moderate severe. on average. We had no criterion, exclusion criteria, other than they had to have a diagnosis of dementia.
Yeah. So you had this intervention. What were you hoping to change?
Well, we had our primary outcome was dual. We had two primary outcomes. We had hoped to reduce neurobehavioral symptoms in people who were living with dementia and reduce caregiver strain among the caregivers. Those were the two primary outcomes.
Yeah. And the NPIQ, which was the neuropsychic inventory one, measure of those behaviors, did these people have high baseline levels of behavioral issues or caregiver strain?
Yeah, considerably higher than you or me. They had symptoms. I believe there are 15 items on the NPIQ, and they ranged anything from apathy to aggression, agitation, sleep disorders. So most of the people had 2 or 3 symptoms.
Okay.
Yeah.
We'll get to Greg's article because Greg, you used NPIQ as a primary outcome, right?
Yeah.
So maybe we'll hold off on the NPIQ question until later.
Yeah. I was wondering if we were going to get into that now. We'll get into that in a little bit.
Let's quickly, because I want to talk about both of these articles. I think that an interesting comparison. But real quick, David, what'd you find? David.
All right, we're going to do with what did you find? Sure.
Okay. So we had kind of mixed outcomes. The two primary outcomes did not differ among the 3 groups. Not only did they not differ among the 2 interventions, but also the third group.
So no difference in behavioral outcomes for the patient, no difference in this caregiver
strain index, or distress from behavioral symptoms, or PHQ-8, which is a depression. None of those differed. The one secondary outcome that differed, and it differed significantly with both interventions compared to usual care, was caregiver self-efficacy.
What does that mean?
That they felt they were able to manage this disease better.
Okay. So they felt like they could do it better, but there was no difference in strain, no difference in depression symptoms, no difference in behavioral outcomes. What do you make out of that?
Well, there are many interpretations. One interpretation is that, I'm interested in Greg's take on this, is maybe the neurobehavioral symptoms and distress response is not the right outcome.
Yeah.
Maybe that's not, maybe that's too hard an outcome to move. And maybe it's not capturing the right things. So one of the questions is, are these the right outcomes? Yeah. The second is, and this is a lesson I would give to all budding research, do not do a randomized clinical trial during a pandemic.
Right.
Not the right time.
You should have known better, David. Should have known better.
Yeah, it's wrong time to do this because, and I'm certain Greg ran into this as well, but these community-based services, as you want to refer people to, closed, right? The people who were living in assisted livings, their family couldn't visit them. They couldn't get caregivers. All sorts of things that really what we anticipated would be parts of the intervention couldn't be delivered, plus all the psychological overhead of the disease itself.
I got a question, though, David. Let's say that study was wildly positive. Would you say, though, the generalizability of it should be thrown out of the question because it occurred during a pandemic, and post-pandemic, we're not in the same environment? Like, would the opposite have been true too?
Well, that would advocate for having more pandemics. Try to have a pandemic going all the time because those are the only conditions under which it works.
We're working on that.
We are working on that. Right. No, but the question is, like, when we do these studies, like maybe in an era in pandemic where there are not a lot of other resources, adding this extra layer of support actually helps in those times. But should we think differently?
Yeah, maybe it's like a high bar to pass, right? If this actually shows a change during a pandemic, then wow, what's it going to show outside of a pandemic?
Or will it show anything because the resources weren't there?
There are 2 ways to look at it. Yeah.
Yes.
I do want to ask the question about the primary outcome.
Yeah, we'll get
We'll get to that. But before we do, let's actually talk about Greg's study, because I think it's going to be an interesting comparison between the two. Greg, so you did your study, which is comprehensive dementia care, but on top of that, layered palliative care. Is that right? So this is the in-peace study. What did you do?
So the layering of palliative care was essentially by having the interventionists, who were a nurse and a social worker, each caring for a group of dyads of patients with dementia and their family caregivers, who were trained in palliative care in addition to the dementia care management model. And so the social worker had worked in hospice previously. The nurse had worked on another palliative care grant, and they were both trained in advanced care planning and goals of care conversations. So we had specific, sort of modules that we wanted them to try to incorporate into their ongoing care. And their intervention was contacting the family caregiver on a monthly basis and trying to pick up early on changes in patient symptoms, caregiver distress, other kinds of clinical changes, so that we could intervene quickly and hopefully before people needed to go to the emergency room or hospital, or even necessarily go to their clinician, like their primary care doctor. And we're a little bit different than what David described. We were doing this in central Indiana in two health systems, collaborating with their primary care practitioners. And our entry criteria included that people had to have more advanced disease. So we set it up so it had to be fast stage 5 through 7, so at least significant impairments in activities of daily living. But it turned out we enrolled people with only stage 6 and 7 for the most part. There were only a couple of people in stage 5. So we ended up...
These were all community dwelling people.
Yes, they had to be community dwelling.
Dementia.
That includes assisted living, but they couldn't be in a nursing facility, and their caregiver had to have regular contact with them on a weekly basis. And like David, we picked the NPIQ as our primary outcome. And the secondary outcomes included the caregiver distress from the neuropsychiatric symptoms, patient symptoms as measured by the SMEOLD, which is a measure of symptoms late in dementia, the PHQ-8, so caregiver depression, and then very importantly was a measure of, you could call it healthcare utilization, but from a palliative care perspective, keeping people out of the emergency room in the hospital is a good thing and keeps them from being harmed and suffering all sorts of iatrogenic things. So the combined outcome of ED visits and hospitalizations was our last outcome. And,
David, did you look at that outcome too, utilization?
Well, I was very interested in how Greg got these data. We are funded to look at utilization. That was one of the specific aims that the National Institute on Aging funded us for. However, there's a problem getting that data out of Medicare, the claims data.
Yeah.
Not so much for fee-for-service Medicare, but for MA, Medicare Advantage, there's a 1.5 to 2 year delay. And we're still in this waiting for Godot kind of situation.
All right. So hopefully we can see that data sometime soon.
So yeah, we did not want to deal with the nightmare of Medicare data or dealing with Medicaid, Medicare, managed care. And so ours is based on the fact that we have a very robust health information exchange, many decades old here in Indianapolis. And so there's an arrangement where we could get the permission of the caregivers and patients to access their data through what's called INPC, so the Indiana Network for Patient Care. And so we actually have, the nice thing about it is we could pick up on ED visits or hospitalizations throughout the region, not just in the two health systems where we were enrolling patients.
And David, can I ask, Greg, can I ask one more question about your study? I guess David too. When I think about, a lot of the trials for drugs in dementia, it's a super white, wealthy population, and they cite a lot of reasons why they can't have more diverse populations. Same thing with yours? Super white, wealthy?
No, we had almost 40% African American or Black, and we're fortunate. And
Wait, so it can be done?
yes. Yeah. We made an effort, but we're also fortunate to be building on a tradition here where we have one of our health systems is a safety net health system that's very well trusted and loved in the community and has a history of having people participate in research. And so that's some of the things, we had an old, very frail, home dwelling group of people with a high proportion of people who were Black and from a resource poor community.
David, how about yours?
So we're about 21% non-Caucasian, non-Latino. So it was including African American, Black, and Latino. It's about 21%. So pretty representative of the population.
Mm-hmm. So fascinating. I loved your studies. And I think, Greg, your study shows, yes, we actually can enroll very diverse populations in these dementia trials if we cared about it. Yeah.
Yeah. What did you find?
So like the DCARE study, the NPIQ did not move. So we didn't have benefit in the neuropsychiatric symptoms. We also did not have any benefit in the other symptoms for the patients or the caregiver distress or depression, but we had a pretty dramatic effect on ED visits and hospitalizations. We literally cut them in half, both individually and the combined endpoint were reduced in half, as you said, during a pandemic. So if we were able to have a pill that was the equivalent of NPs, we'd be making, billions of dollars in the sense of, being able to reduce that kind of utilization.
Well, I guess the question for that is, if this was a pill, I love this program, has great face validity, but if I was having this podcast about a pill, I would be saying, but the primary outcome was negative here. This was a negative study. The hypothesis that it would improve behavioral symptoms just was negative, and all the other distress didn't change. These other things didn't change. Are we just picking and choosing? Hey, here's a secondary outcome that's positive. Would we have that same bar if it was a pill? I'd probably say no. What do you think about that?
I think you have to categorize these into two big categories. One is clinical benefit. And I would say that both of these studies showed less clinical benefit than had hoped. But I think that utilization is also a very important benefit, because if it can reduce utilization, as the NP study showed, that all boats rise. That means more money to do other things, to implement things like guide, et cetera. If you're spending less money on recurrent emergency visits or hospitalizations. So either if you hit a home run either way, it still adds the score.
Yeah, and I think that we're sort of, in some ways, the drug paradigm and the FDA and highlighting primary outcomes is something that we're kind of stuck with. But in some ways, we could easily have picked the ED visit and hospitalization as the primary outcome. I mean, we wanted a home run where we made things better for patients, caregivers, and the healthcare system. And we have colleagues who are doing other kinds of studies like this where they flip it around and put the utilization as the primary outcome. So I don't feel as strongly about that we were fishing for something else. I mean, this was a pre-specified outcome. It was one of the main aims in the grant proposal. Yeah. And it would be sort of silly to say, oh, it's not important after we kept all these people out of the hospital.
Great point. I guess another question, because let's talk about the NPIQ. So this neuropsychiatric inventory. When I think about neuropsychiatric symptoms, I think about, we had Helen Kales on.
Helen Kales.
Who talked about management of behavioral symptoms in dementia. And she said, you can focus on three things. You can focus on the patient, you can focus on the environment, or you can focus on the caregiver. And what do we do as a healthcare system? All of our focus is on the patient. Which is the one that we can't change? Generally the patient, and we ignore the caregiver and the environment. And when I look at the NPIQ, so this neuropsychiatric inventory, Like when we look at the severity, I wonder how much can we actually change? Like, is the patient impatient or cranky? How important is that to change? Can we change it? Should we change it? Do they have difficulty coping with delays or waiting on planned activities? Does the patient engage in repetitive activities such as wandering around the house, handling buttons? Has the patient lost or gained weight? Like how much?
What about the happiness one?
Oh yeah, there's one on like.
Are they excessively happy? Is that a problem? Do we need to fix that?
And if it's a problem, whose problem is it?
Is that what we do as geriatricians and palliative care docs? We reduce excessive happiness.
So how important is the NPIQ to be modifiable? Because when I think about it from a geriatrics and palliative care perspective, like if they're wandering, I think about, okay, like the patient's wandering, how should I focus on the caregiver or the environment to help with that and maybe less about the patient? Thoughts on that? I'm going to turn to you, David, first.
Yeah, I think Helen says a couple of things that she alluded to that are really important. Number one, these behavioral symptoms, particularly agitation, aggression, those kinds of things are remarkably difficult to treat. The literature supports that behavioral interventions are best for behavioral symptoms, but sometimes they don't work. And when we turn to drugs management of these symptoms, the drugs are lousy. Yeah. They're not very effective. They're dangerous, et cetera.
Pretty much across the board.
Yeah. So, if I had one wish, for the holidays, it would be a drug that really worked for behavioral symptoms. But I don't anticipate that gift coming. Yeah. So these are very, very difficult to modify.
What do you think, Greg?
Yeah, I would agree with that. And sometimes what we end up doing for families is helping them manage and cope with those things. And so we even have people who show up not only in our trials, but in our clinic where, things are still just as chaotic and just as challenging, but the distress that the caregiver is having may have improved because, as David's study focused on, was their self-efficacy, their confidence, their ability to just handle these things may improve. So I also think that, one of the things that we put in our paper and a subsequent letter was that our NPIQ baseline, we didn't think it was that high, and it also didn't change much in either the intervention or the usual care group. So it's still possible that there are people who weren't in our study, who have much more distress and would have benefited more.
Yeah. So if you enrolled people with higher degrees of distress, maybe you would have found a bigger benefit.
Even consider making that an entry criteria, at least for a study.
Well, I guess another question for you, Greg, is this idea that going back to this secondary outcome, reduced utilization of ED and hospitalizations, like that's a big finding. How much of this is that this idea that, we probably can't change much as far as the patient behaviors. Maybe we shouldn't even be changing. Like, so they're wandering. Like, make sure it's safe. Like, make sure so they're excessively euphoric. Like, okay, let's talk about the caregiver. Why is that so stressful for you? Like, what's bothering you about their apathy? How can we think about that from a caregiver distress standpoint? And maybe we can focus on that distress. With that said, your study didn't show an improvement in distress, but it didn't show a worsening distress. So you actually had these people, and this is, we talked with Ken Kavinsky about it.
Can I give this story? Yeah. So you see, there's a bike behind me. That's my bike. Biked in today over Golden Gate Bridge. Beautiful commute to work. I think it was Greg LeMond who said, you work at this, you cycle, but it never gets easier. You just go faster, right? And I think Ken said, for caregivers, they will always work themselves to the point of exhaustion, right? And if your study allows them to do more, they will do more. They will do more care at home if the patient's not in the hospital. They will always work themselves to exhaustion. So he found it reassuring that they were able to feel like they knew what to do more from David's study, and they weren't going to the hospital and the emergency department as much, and there was without increasing the caregiver distress. because they will always work themselves to that point where they are exhausted.
And he also brought up this. We had a podcast with David Currow talking about dyspnea, and David brought up this fact that it's really hard to do a study on dyspnea because what happens, similar to what Alex was talking about, people are going to push their function to the point of dyspnea. So if you improve their dyspnea, they're going to walk farther, and they're still going to have that 10 out of 10 dyspnea, but it happens maybe 50 yards down the line. So thoughts on that, Greg?
Yeah, I agree with that. And I think our original draft of the manuscript actually sort of put the notion of how we could see the lack of change in many of these symptoms as a positive outcome.
Yeah.
That they were keeping people at home, nearly, more than 3/4 of the people in the intervention side didn't have a single ED visit in the 2-year study.
Wow.
Yeah.
I mean, they really kept people at home.
What was the mortality rate again? Like 40%?
40%, yeah.
40%.
So they were able to keep people at home, manage all of these very challenging behaviors and issues in advanced dementia during a pandemic.
Without worsening distress or depression.
Right.
Yes. I think that's remarkable.
Yeah.
One of our site PIs said, that what struck him the most about the data is that over a 1.5 year period of time, with the progression of dementia, with COVID, with all this other stuff, we didn't see these precipitous declines. So maybe holding steady is a good thing. But once again, the usual care group was similar.
Yeah, that's what it's going to be interesting to see what happens with utilization in your study, David. Are you going to see potentially similar results? Which I guess kind of moves us into what do we do with this data? We have these studies. It seems like there's, we're still waiting for some more data on your study, David. What does the future look like? How should we be using this data to kind of move us forward and move comprehensive dementia care forward?
Well,
big question.
A lot of these kind of preliminary data for GUIDE, and I think GUIDE by and large is on the right track.
And real quick for our listeners, so we did do an episode on GUIDE. We'll have a link to it, but if you can summarize GUIDE in one sentence.
Yeah. So GUIDE is a new program. It's like a 8-year demonstration program for fee-for-service Medicare beneficiaries that is an alternative payment model. So it gives a monthly per beneficiary payment for managing the dementia care. And it does something that Medicare has never done, and that is to pay for respite care. It's the first time they've ever done anything for caregivers. So there's a lot of administrative work to get GUIDE up and running and to deal with the CMS requirements. But it is a new way of thinking about and paying for this kind of care. So they will evaluate it. It won't be a clinical trial, but they will evaluate it in many ways, shapes, or forms. But the point of the matter is, is that 74 million of us baby boomers are approaching very old age. In 2036, the first of the baby boomers is going to be 90 years of age. And when you reach 90 years of age, your chance of having dementia is about 1 in 3. So there's going to be this explosion in the number of people with dementia. There's this old saying, I think it was Mark Twain, but if you think education is expensive, try no education. Try ignorance. And indeed, there will be additional updates on these models.
Yeah.
But
how do you think your study should influence those models?
I think our study shows, I think that the big take-home message from our study, and we'll know more about this when we look at the quality indicators, is that there are many ways to skin a cat. And that one of these models is not better than another. They both provided very comparable care. And so it really depends upon the healthcare systems, the kind of resources they have, which model to choose from. But they're better off with an established model, particularly one that has some evidence behind it. so they don't make the same mistakes that Greg and I and many others have made over a number of years. And the materials are ready, and there's people who can help you get these things started, et cetera.
And you have the trainings, and you have the
dementia is not going away. Even in the best case scenario, the new drugs, et cetera, it's not reversed. And none of the patients in Greg's study, and very few of our patients, would have been eligible for these drugs.
For the MABs.
Yeah.
So the amyloid antibodies, they're not the ones.
Yeah, it's only going to be even able to be used for a very small percentage of patients. There are some studies that put it well under 10%, perhaps under 5%.
And people still progress. You're not stopping them.
You're not eliminating the disease.
They're progressing just slightly slower, if you believe they
they will progress to the point of being ineligible. The big question is, will they be deprescribed the medication, or will they continue though?
They will be deprescribed. In fact, one of the drugs is that if you don't show clearing of amyloid a year and a half later, they won't pay for the drug anymore. The drug stopped.
But I think that back to what David first was saying about what we learned from these studies, I think it's easy to pick on the primary outcome, not having been moved in both of them. But if you think about the environment in which, like, our study took place, perhaps one of the other things is that, we had enough going on in our environment where the usual care people, like three quarters of them who died ended up enrolled in hospice. And most of those people died at home. So we may already be, very different than from some places where literally they have nothing. And so David's point about GUIDE, that Medicare doesn't pay for education of caregivers. It doesn't provide a lot of wraparound supportive services. It's never paid for respite. And even within managed care, it's not so easy to get that sort of stuff. So I think that the GUIDE program and our models are moving the field in the right direction. And we just need to figure out what are the things that are the right things for the people at different stages and with different kinds of issues that sort of come and go throughout the course of the illness, so that we can tailor the intervention to the dyad.
Do you have an idea of costs? Like, we have an idea what the amyloid antibody costs, I think $25,000 to $30,000, plus you have to add on per year.
Per year.
Plus you have to add on all the MRIs, PET scans, and other things, probably close to $100,000 per year.
For implementing our program, for 100 people who were in the intervention, it was a nurse, a social worker, and 10% of a doc. And our sort of estimates, not using Medicare data, but using things from the literature, suggested that the ED visit and hospital utilization decreases would save something like $900,000, which would more than pay for the intervention. So I think it's, it's not as sexy as antibody MRIs and other sorts of stuff, but it's the sort of thing that when we haven't published some of the qualitative data that we have. I mean, the people in the study were really sad when it ended. They had the same person calling them like every month for 2 years and was available to them like at night and on the weekends, or somebody covering for them, so that they felt like they got a lot out of it that wasn't measured by the NPIQ or other metrics we use.
So have health systems taken up this program and initiating it on their own?
Well, we've had one health system specifically come to us to talk about implementing it in managed care to decrease costs. And we have one large insurer that started some conversations with us, again, targeting their managed care practices. But I think that, the GUIDE model is being implemented in hundreds of systems or practices around the country. And I think part of what we want to be able to do with getting out the positive side of what's been done in these and other studies is that these are things that other people could implement and that they are worthwhile implementing.
How important was it, the layering of palliative care, though, in your intervention, you think? Was that a large part of the intervention?
Well, it was in the sense that, we started off with, advanced care planning and goals of care conversations for everybody in the intervention side, circled back to it on at least an annual basis. And when there was a major change in clinical status, and had lots of discussions, not only about should you go to the ER or the hospital, but even sometimes we'd field questions about, does dad really need a colonoscopy given everything that's going on? Or, the cardiologist is thinking that he might need a pacemaker, and we'd help talk through some of these other kinds of decisions. And that's not going to be reflected in the NPIQ, but I think it had an impact on the nature of the care of somebody with very advanced disease and an incurable condition.
David, what's next for your study, D-Care?
I just wanted to address something you raised earlier about the costs. And we actually looked at this in D-Care. For the health system-based dementia care, on average, it was about $1,980 a year. Okay, not a month, a year.
What, 1,980?
Yeah, per person per year. And then for the community-based dementia care, it was
so like a tenth of the cost of just the drug for like a amyloid antibody.
Yeah, but I don't know that's
probably
a fair comparison. I'm not sure that's a fair comparison. But and for the community-based, it was $1,217 a year. So these are not hugely expensive interventions, and certainly in line with what we would expect for shouldering costs by Medicare. So what's next for us? Well, next for us is a lot more analysis. We're going to, utilization data should be available by the end of the year, and looking at those. Certainly, I think if it shows any benefits in terms of cost reduction, Medicare would be very interested in that. But the other thing we're doing, and we would love to have Greg aboard as well, is that we're trying to help new guide track participants adopt established dementia care programs and spread dementia care. Because to be honest with you, there are 7.2 million Americans who have Alzheimer's disease alone, and guide is only going to affect 200,000 of them.
Yeah.
So that there are institutions that are not participating. Medicare Advantage is an exclusion for guide participants. So there's a lot of work to be done.
Can I ask one other question for both of you? Because we've talked about these, some of the negative findings, some of the positive ones. How does this fit in with some of the other research that you've both have done? And I think about the care ecosystem. So we did it. We'll have a link to that on the show notes. Kate, how do you say Kate's last name?
Posehn.
I always and Sarah Delaney on our podcast a while back, and they showed positive improvement in quality of life. I think that was their primary outcome, like a pretty robust finding using these health navigators. How does this fit in with those studies, and how should we be putting it all together in these guide models?
When we looked at trying to situate the in-piece results, we didn't yet have the D-Care. But we had a table where we were comparing, internally these other studies, including care ecosystem. And I think that it's not that everybody has to have exactly the same thing. I think that depending on what's in the environment and the health system and what kind of dementia care practice is available, that many of these things can be adopted and adapted for use, and what fits best for a particular area with their resources and their personnel. So I would say that they all belong in the toolkit.
Yeah, wonderful. Dave, any other thoughts on that before we end?
No, I think that there are at least 7 programs that have evidence base, including Care Ecosystem and ANP's Alzheimer's Dementia Care Program, BRI Care Consultation, Mind at Home, and Integrated Memory Care, and they all have some data to support them. And they all have great model developers who, have been very generous in trying to help other institutions get something going. Because in the end, people with dementia affect all of us.
Yeah.
Every person is touched by dementia.
Yeah.
Yeah, and also to mention one other podcast that we did early on that was a prior IU UCLA connection, and that was with Chris Callahan and Lee Jennings, who's a mentee of David Rubin's. She's now, I think, in Oklahoma.
Yes.
And their podcast title was "It's Time for Comprehensive Dementia Care," and I think this is more evidence to that effect.
We just got to give it a chance.
That's right.
That's
Give it a chance. Here we go. A little bit. Everybody's talking about ministers, sinisters, banisters and canisters, bishops and fishops, and rabbis and Popeyes. Bye, 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 byes. All we are saying is give peace a chance. All we are saying is give peace a chance.
Greg, David, thanks for being on this podcast with us, and thank you for the great work that you're doing, your teams are doing too.
And the great work that Jerry Powell's doing. Thank you.
And thank you to all of our listeners for your ongoing support. We'd also like to say a big thank you to those who've donated more than $250 to the Jerry Powell podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstadt.
a very big thank you. And if you too want to donate to the Jerry Powell podcast, please go to the Jerry Powell website and click on the blue or orange donate button.